see my screen, Ahmed, Dr. Ahmed, yeah?
Yeah, I can see it clearly. Yeah.
Yeah, so this is a case that's coming to the nurse. Okay, Jack Mack, 55 years old. Okay, uh, shortness of breath, not massive. Okay, um, the nurses did examination. His vital signs is fine. This is his history. She did an ECG, and then she's coming to take your opinion about the ECG, and she's worried. Um, so do you want to read what his data, and then I will show you the
Yeah,
ECG?
yeah, sure. So this is Jack, male patient, 55 years, having short of breath. He is on multiple medication, metformin, dapagliflozin, ramipril, and bisoprolol, um, Trembo, salbutamol. Yeah, so it's a mixture of medication. Actually, so he's diabetic, kind of for asthmatic patient or COPD. Yeah, he has COPD. Yeah, he had cabbage and hypertension. Okay, so yeah,
Yeah, so you can see his multiple risk. Okay, you have cabbage.
yeah,
Okay, and then the nurse worried, and then she bring you this ECG. So
yeah.
doctor, what to do next?
All right. Well. So is the patient is only having shots of breath, no chest
Shortness breath.
pain.
No, no
There's no
chest pain.
other. All right. Okay. Uh,
I will
all
look at
right.
cards so we
Yeah,
can see,
yeah,
and we'll
yeah,
discuss.
yeah,
No,
yeah,
no, there is no
yeah,
stress. Yeah, we'll discuss.
yeah,
You
yeah,
know,
yeah,
it's
yeah.
not. Yeah.
Yeah. So again, we go systematically and see we again uh, um, rate rhythm, axis deviation, and then we look at the PRQ, PRQST complexes. So this patient most likely to have so this is almost 100 p per minute. Um, uh, so this is most likely to be regular rhythm. Axis deviation is left axis deviation. Um, well, what I can see here, the PQ, I can see the P wave followed by QRS. The QRS complex is quite wide QRS.
Mm-hmm.
What I'm thinking here, this is most likely to be what do you call it, left bundle branch block.
Yes.
Um, so yeah, we need to establish if this is a new left bundle branch block or not. So we might need to have a look at and a previous ECG and see if this is a new
Exactly.
one. If not, we
Well,
can
mm,
apply Scarboza criteria.
okay. Yeah. Excellent. But then there is no ECG. Okay. Unfortunately, there is no old ECG for the patient.
Well, I would consider it a new. I would, from my side, I would consider it a new left bundle branch block, and yeah, I will probably will have to send this patient away to the A&E to do. I mean, if because it might be a new MI, most likely new MI. So yeah, because the short term breath,
No,
maybe, yeah,
you said a very good one. 1 minute, 1 minute. Don't run. You said a very good thing. You said it's Scarboza criteria.
yeah, yeah, yeah.
You are, so is it
Well,
Scarboza positive or negative? But this is
okay,
important because,
so.
yeah, because if it's, yeah, so how you will differentiate between the new onset left bundle branch block and old onset left bundle branch block in acute setting?
All right.
Or in the GP setting, because well, you will find that. Well, I met a couple of cases in the last week with the same case presentation, and then there is no old ECG, patient have cabbage, and
Mm.
then I need to take a decision. Okay, is a new left bundle or old left bundle? Okay, so you
Well,
said that
again,
very important. Well, it's
yeah,
Scarboza criteria. So is it
yeah.
positive Scarboza or negative?
We have to look at the is it concordant? I mean, is the elevation is concordant or discordant
Yep.
with the R wave QRS complex. So if this is discordant, I mean, I would think about, if this is more than, I think, five five small square, or then and the QRS here is negative. So I would think this is more likely to be a new length bundle branch block that consistent with new myocardial infarction. And then
One
if
minute, 1 minute, 1 minute, 1 minute. So is this concordance is good or bad?
what do you mean is good or bad?
Yeah, I mean, is this concordance is good or bad in left bundle branch block? Is it something good or bad? You are
According to
worried
the
if you are, yeah,
Scarboza is bad. Yeah, if it's more than,
no, yeah, no, this is excessive disconcordance. So
yeah,
there's
yeah, that's what
difference.
I'm saying.
Yeah.
It's more than, yeah,
So,
more than
yeah.
certain
So,
limit. Yeah, yeah, yeah.
yeah. Well,
Well,
the
if it's
13.
less than
Yeah.
this, is if less than five square, I guess that's what I remember. Five
Yeah.
small square or big
Yeah. You
square,
are
one
right.
big square.
One big
That,
square. Yeah. Which.
yeah,
Yeah. You
yeah,
are right. Which is smallest square, which I cannot see here anywhere. Do you find it? Five big squares. I can't see.
yeah, yeah. I
Maybe
can't.
here
No, I
little
can't see
bit,
it because
and
it's
yeah,
really small.
maybe
You need to,
here, yeah,
you need to have an
maybe here little
amplifier.
bit, but yeah, I can amplify it. I can, no
Yeah,
problem. I mean, because that's important. Applying this to real life scenarios is
yeah.
important. Okay, and you will
Well,
find that you will
it's
meet that in your life.
it's in, like, if you say in here in V1, it's kind of borderline in one of the waves there.
No,
Um,
why? See here? Well, here, okay. So if you will see the ST segment elevation, you are comparing it to the PT wave after. Okay, so this
yeah,
is your baseline. So your
yeah,
baseline is here. Okay, and so this is the elevation. It's for sure the elevation less than one big square. Okay,
yeah.
and here
Well,
the
the other
elevation
one,
less than
the
big
third one
square.
is kind of like,
Yeah, well, the third one seems to be almost always one big square, but it's only in one wave,
yeah,
so you can
yeah,
discard it. And
yeah.
what is new, maybe you will learn it from me today, is something called Smith's modification of
Yeah,
Scarboza criteria.
yeah,
Okay,
there is a new,
so
yeah,
I
classification.
will explain that. I will explain that. So let's. So what you wanted to say more, because I just need to explain what is a Scarboza to the audience, and then we will
Yeah.
will explain what is a Smith modification. So what is the what you wanted to say more, other than Scarboza? You wanted to say something else?
About DCG itself.
Yeah, yeah, yeah. Well, there for me, I think there is nothing else. But I because I cut your train of thought. Sorry.
No, not really. I was just, yeah, this is like, as I said, we need, if you have an old ECG in hand, then you can, of course, that can save you the hassle, and you can
Yeah, sure,
always, yeah.
sure.
So yeah, and yeah, I would just be in the safe side as well. You do run all the investigation. If I have some sort of investigation to do, like a point
Yeah,
of care,
you have
throbbing in.
you have point of care chopper in your because
Yeah,
I didn't see until now with GP. You have
I had it in one
you
surgery
have
before, but they
okay,
rarely
that's good.
use it. They
That's good.
rarely use it. But
That's good.
if you're being doubtful about any new changes in the ECG, then just send the
Yeah.
patient on.
Well,
That's in
yeah,
the
yeah.
protocol.
This is the rule. Yeah, this is the rule.
Yeah,
I'm completely with you. But knowing about Scarboza criteria is important. This is one.
yeah,
The other thing we need also, because the people are mixing between Scarboza criteria and non-STEMI. Okay, if this is
yeah,
a negative Scarboza criteria and they still have suspicion that might be, patient might be presented with heart, with unstable angina or
yeah,
non-STEMI, then the Scarboza
yeah,
criteria cannot exclude that. The
yeah,
main use of Scarboza criteria is to exclude ST segment equivalent cases, okay, which is indicative of, urgent primary PCI. But still, the patient can be presented with non-STEMI. Okay, he's having shortness of breath, he's diabetic. Okay, does this shortness of breath related to non-STEMI and or atypical angina? This you need for sure to investigate it more. Take the history from the patient. If you are quite sufficiently sure that this related to his maybe bronchial asthma or COPD, then that's it. But if you have still doubt that that may be atypical angina or atypical, acute coronary, then you might consider referring him. But if you are thinking this is STEMI, then the Scarboza criteria is your way to go.
Yeah,
So yeah,
the problem about the Scarboza, it's specific, it's specific. If you have negative or no Scarboza criteria, then it's kind of excluding
the
the
STEMI,
MI,
yeah,
but
yeah,
it's
yeah.
not sensitive. That's the problem about it. Yeah,
That's why they make grading. Okay, so if it's
yeah,
3 or 5
that's true.
or more, yeah. So if you have
That's
one
true.
criteria, you can't use it.
Yeah,
If you
the
have more
score,
than
yeah,
one, you
the
can
scoring,
use.
yeah,
Yeah, yeah,
that's right.
yeah.
Yeah,
So basically, in the left bundle, oh my, this will. Yeah, so we will see what is the normal left bundle, okay, and then we will discuss what is the Scarboza criteria. But just in general, you need to know that this concordance mean that the shape of the main vector of the QRS complex, okay. The main vector here, for example, in V1 is negative, okay. So that this concordance mean that the ST segment will be elevated. Mean that if the main vector and the QRS up, then the disconcordance and the ST segment will be depression. And if the main vector in the QRS complex is uh, down, then the main sorry up, then the ST segment will be down, and the main vector if it's up, then the ST segment will be the opposite. Okay, I'm not sure if that clear or not. For example, here this is the main vector of the QRS complex is down. Yeah, the big wave is sticking it the vector to down. Then having elevation is normal. Okay, there is proportion between the depression and the elevation, and this is the Smith modification, and I will explain that. Okay, again, V2, depression, elevation, V3, depression, elevation. Okay, and the rest here, you can see the vector is elevation, and then the ST segment depression here, you can just ignore it, okay, because that's normal in the left bundle branch block. The Smith modification or the excessive discordance. So sometimes there will be something called excessive discordance. So all of them, the QRS complex is against the ST direction. Okay, you can see in all leads. Okay, all leads, the QRS complex is in the opposite direction. So is this excessively right or not? So the excessive discordance mean that if the ST, there is proportion between the length of the deepness of the vector of the QRS and then the amount of elevation. Okay, the original Scarboza criteria was saying if the elevation more than one big square, especially in V1, V2, V3, then that means that this is positive Scarboza. This can be an MI. But then Smith, which is French cardiologists, say no, this is not quite. There is a proportion, and the proportion is 25% of the depth of the T wave, ST the depression, and the length of the elevation. For example, or in other words, every big square of the ST segments or of the deep S wave is equal to small square of the ST segment elevation. If it's more than that, then that means excessive discordance. For example, here you can see that the T wave, the QS complex is 1, 2, 3, 4 big square. Then means that the ST segment elevation, if it's more than 4 small square, then that's abnormal. Okay, and you can see here if we draw a line So it's around 3 small square. So that's normal. We came here, this is 1 square, 2 square, 3 square, 4 square, 5 square plus. So if this is more than 5 square, then this is a problem, but you can see it's only 3 square. And vice versa, okay? This is what is the Smith modification is. Coming back to the PowerPoint, I know that the people might not find it interesting because it's not an exam case, to be honest, but it's real life cases, okay? If we came to how you can diagnose left bundle branch block. So this is the criteria of the left bundle branch block. First, you need to have delayed conduction, which means that the QRS complex is more than 3 small squares, okay? And then dominant S wave in the anterior lead V1, V2, and V3, and then dominant R wave in the lateral leads, and I will explain why is that. And then the prolonged peak time and absence of QRS complex could be an accessory an accessory confirmation of the left bundle branch block. And you might also find also left axis deviation for sure. And in simple terminology, if you have W in V1 and M in V3 and V6, this is a left bundle branch block, okay? So which is R dash R, which is rabbit ear in the V6, and W and V1. So this is a left bundle branch block, just in short, okay? But it might be incomplete left bundle, then this is another story, and we might take such examples in the future. We need to know first the basic and then build on it. Okay. So what is the explanation? Why the normal progression of the R wave is abolished in the left bundle branch block? Okay. That because the difference in the conduction. So usually the conduction will be spreading from the atria reaching to the AV node and then from the AV node to both bundles at the same time, right and left bundles, and then that will just move the vector towards the axe of the heart, which is this way. Okay. And in general, if the axe of the heart toward the leads, then this will give a positive wave. If the axe of the heart away from the lead, that will give a negative wave. Okay, and that's why if the vector of the heart is in this direction, okay, you will find the R progression is nicely spread from V1 because V1, V2, V6, V5, V6. So you will find that there is normal progression, slightly progression from V1 to V2. In left bundle branch block, the left bundle will be blocked, okay, and that will make the progression of the depolarization wave going through first the right ventricle and then septum and then toward the left ventricle, okay, and the left ventricle, because of the mass effect, will take the vector toward it. And hence you will find that the vector will be away from V1, V2, V3, and that's why you will have a negative wave in these leads, and then positive wave in the lateral leads, which is V5, V6, and lead 1 and EVL. Okay, I hope that is clear. However, if you cannot make sense of it, okay, scientifically, you just know the criteria of the left bundle branch block. Causes of left bundle branch block, rarely to have a left bundle branch block that is normal. Okay, all left bundle block means that there is a pathology on the underlying pathology, and in such case the patient have already CABG from before, so it is most probably the cause of the left bundle branch block, the previous CABG. However, left ventricular hypertrophy, dilatation, aortic stenosis, all of this are causes of left bundle branch block because it puts strain on the left ventricle, and and that will cause hypertrophy of the wall of the left ventricle, and hence the left bundle branch block will appear in the ECG. Again, revising of the morphology, okay, looking at the lateral leads, you will find R waves or rabbit ears or R dash, okay, or QS or RS wave. Okay, but in general, it will be the positive wave with the M wave in the lateral leads. This for V1, as we said, it will be deep S wave, okay, or R small r S wave or QS, okay. So this is the normal morphology of the bundle branch block, and then we will talk about this concordance, which you said that there will be if the QRS complex towards the negative wave, it will be the ST segment will be elevation. If the QRS complex is positive, then the ST segment will be depression. Okay, so this concordance in left bundle branch block is normal. Okay, what we are looking for is excessive disconcordance, which is in this slide. Okay, so what are the Scarboza criteria? So this, if the QRS complex is positive and there is ST segment elevation and it's more than 1 millimeter, that's considered to be Scarboza positive. Okay, and then in V1, V2, V3, if you have an ST segment depression with deep S wave and more than 1 millimeter, then that's considered to be positive. Excessive disconcordance, which we said that there is a modification. The Smith modification is what I said. If there is ST segment, deep ST QS wave or deep S wave, and you will calculate the number of the big square, and every big square will represent a small square here. If the number of the small square outcoming the number of the large square, then this is considered to be again positive Scarboza. Okay. Usually you need more than one criteria to consider that the patient have an infarct, okay, because each criteria have a mark, and then if the marks is more than 3% or 3 marks out of 5, then this is a positive. If it's less than 3 mark, then that is non-specific and not sensitive. Yeah, so this is all what, and this is some examples, okay. I hope that clear, doctor. I know that now most of you went, so we went from nearly 30 to 11. I know that is not an easy, okay. It's needs you to read it more than once, okay, and then that will make sense. But I think it's very important to know the Scarboza criteria and the general practice, because it can save you from a lot of hassles. I'm open for question if anyone had question. If not, I'm happy to conclude for today, and I hope I will see you all next week. So shall I finish the teaching, doctor? Yeah. Okay. So I will close the recording.